record. All right. Well, welcome in everybody. We've got one participant live, which is great. And I'm going to learn that 11 a.m. might not be the easiest time on a weekday for everybody to jump on a Zoom call. But hoping that we get some later virtual viewers who this is going to be helpful for. My name is Dr. Karen Duncan. I'm a physician here at Coeur d'Alene Healing Arts, and this is our September open forum where I'm talking about labs. Your blood work. We could really expand this into abnormal labs and, alternative labs and stool labs and urine labs and toxins and all kinds of things. If this is something that people are enjoying talking about and understanding. But really, I came on this topic because, well, for my whole career, really, but really in the last few months, I would say more and more people are coming to me with their, I call them Medicare labs or their wellness check labs. And like, oh, my doc says everything's fine, or I request external records before I go to, write a lab order. And I'm seeing abnormals, bolded abnormals, not just abnormals in my opinion, but actual out of reference range. And I'll message my patients and say, hey, what's being done about this? Who's talked to you about these abnormal values? And they'll be like, I haven't heard anything. My doc or my nurse says everything's fine. And that was that. And so, I really want to be a strong advocate for, the body can heal. Labs are a snapshot in time. So it's not always meant to say, hey, we need to ring the alarm bells because you have some abnormal labs. But it is necessary to communicate. And what I'm seeing more and more in the advocacy world is that y'all have a wealth of information at your fingertips with not just WebMD now that it used to be 10, 20 years ago, but we've got Google, we've got AI, we've got YouTube doctors, TikTok doctors, we've got people everywhere, podcasts telling you what you should be doing, what you should be seeing, what you should be eating. And folks are listening because the conventional system isn't making space for individuality. And while I say all the time, I have compassion for my colleagues in that realm, and it's not a me versus them situation, it is discouraging to see situations like that when patients will come in with their blood work and say, oh, they told me everything was fine. It's also discouraging. My joke that's probably not real funny, but if you know me or have ever been a patient, I have a little warped sense of humor, is that, your Medicare check is a like prove you're not dead check, right? Like the labs that you get are like, you're alive. I don't know if you're thriving. I don't know what your nutrition status is. I don't know your inflammatory markers. And it's just, they come to me with these labs. I just had blood work done. I don't need to get any more done. And I look at them, I'm like, cool, you're upright. You're on the right side of the ground today, but this doesn't tell me about your health. And you're here making an appointment because you're not well. You don't feel well. So we want to investigate. I really want to start off with that word investigative or diagnostic. When it comes to the insurance world, I'm I want to say as well versed as I can be as a naturopathic doctor in a clinic that doesn't accept insurance. And I want to work with insurance. Again, if you're a patient of mine, I will roll over backwards to try to get your primary in the conventional world to run a lab that's going to be covered. But at the end of the day, we are not making the rules. The insurance companies are. And what they will cover is based on them. A lot of times we can't even run a vitamin D panel under your insurance company unless we can prove you have a deficiency. And so if you sit and pause and think on that for a minute, how do we know you have a deficiency unless we test your vitamin D to show you have a deficiency? So there are some really challenging workarounds that you can do with your insurance companies. But at our clinic, we have actually directly created a negotiation with LabCorp, the company LabCorp here, to do cash pay for some of these labs. And I call them investigative or diagnostic labs. I'm going to go through what that looks like here in a minute and why they're important. I'm going to show you a couple lab orders with all of the HIPAA information blocked out so you can understand why we do what we do. But if you look at a LabCorp requisition, this is what you would get at our clinic. And you can see here all the most common labs that we run with a cash pay priced by it. So typically I can sit here in office and tell you, hey, I think you need, 7 or 8 different labs and it's going to be about $50, $150. I also know just with experience what your copay might be if you try to run it through insurance and they reject it. Which ones of these are typically accepted by insurance, which ones I can code for, which means I know you have a diagnosis of hypothyroidism, so I can run your TSH labs. Now, some insurances will only let me run a TSH. Even if you have a diagnosis of hypothyroidism, they won't even cover a T4 and a T3 in an expanded lab profile to see if it's autoimmune thyroiditis or Hashimoto's. So when we have an informed consent conversation in this office, a lot of times it is, if I feel like I'm running investigative or diagnostic labs, I will tell patients very clearly, if you pay for this first panel, so we can get the information, so then we can code for insurance, your primary should be able to take over from there and manage it and run those labs, because now we've proven that a condition exists. But insurance does not do well at covering diagnostic labs traditionally. Now, some insurances do. And without diving too much into the insurance conversation, it's really important to understand that they don't like to cover diagnostic or investigative labs. So sometimes that is a cash out of pocket. And I'll, again, talk about why I think it's important to run those labs here in a few minutes. So that's just a little bit about the ordering of labs, what people will cover. What is considered a general lab panel or an annual wellness check is a CBC, so a complete blood count that shows your immune system status. Sometimes a comprehensive metabolic panel, a CMP. Oftentimes with Medicare patients, unfortunately, it's a BMP, which is just a basic metabolic profile. So they don't include all of the information there about liver and kidney function. A lipid panel. And I'm looking at sometimes an A1C, a blood sugar, sometimes a vitamin D. Once in a while, they'll run a TSH, and that's about it. That's really what I see on annual wellness checks. So again, when I say, you're upright, that's kind of all it's telling me. And it will give me information about your immune system, about your liver and kidney function, your electrolyte balance, your lipids or your cholesterol and triglycerides, and then your blood sugar. And so, as you can imagine, each one of those is just the surface level information. And if we pull back that layer of the onion, we're going to see, okay, liver and kidneys are a little bit off. What are some other labs we could see to prove why? Maybe there's some blood counts that are off or larger than normal. Well, there's a couple different reasons that would be true. And again, I'm going to go through a couple examples. And so when you get those labs and you're looking to advocate, what I really want people to say is, I got my basic wellness panel. I know that I'm working. I know that I'm basically functioning. I knew that by being alive, but knowing that if there are abnormals on there that are bolded, there's probably another layer of investigation in there. Another metaphor I use is, can we swim upstream to figure out why this value is off? Is there something upstream in your blood or your system or your health that can prove that? So that just talks a little bit about ordering labs. Now, the big rule of thumb for physicians that I really do try to follow is, don't order a lab unless it's going to change how you treat the patient, right? I'm not going to go just curious and digging around in labs and running extraneous labs if it's not going to change the treatment plan. Now, if somebody comes in with a very complex case and they're like, I don't know why I'm feeling this way, I've been to 8 to 10 different doctors and here's the lab work that I got and it's continuing to be very basic, then I might have a really open conversation with them saying, let's throw the kitchen sink at it. Let's test a lot in your bloodstream to see what could be impacting this. And we're throwing a wide net. That happens very rarely in my practice. I do know that there are some of my colleagues and some people in the field of medicine who just, you walk in and you have to do a spit analysis, a saliva analysis, a urine test, a stool test. A lot of functional medicine doctors will have you paying thousands of dollars to do all of these tests, including alternative tests, without knowing, again, what's the closest alligator to the canoe? 9 times out of 10, that alligator is going to be found in your bloodstream. There may be abnormalities in your stool. There may be abnormalities in your saliva. There may be something else to look for. But if your blood values are off, that is you right then and there when you got your blood drawn. And that's something that becomes a little bit more urgent when we're looking at treatment. So that's kind of the first piece of like why we order labs, how we order labs, the obstacles around insurance with ordering labs, some of the benefit of hiring a physician that is outside of that insurance paradigm to look a little bit deeper. So, I mean, Carrie, you're the only one here right now. So do you have any questions so far?
I love this, my own private lecture.
Yeah.
Um, well, interestingly, um, when you were talking earlier, I have a mainstream doc that I keep for this very purpose. And with all those last labs you ran for me, you did say you weren't sure some of them were going to be covered. And, I needed as much coverage as possible from an insurance standpoint. So I called them to see because they have a lab in their little building.
Hmm.
I said, can I come to you to have these tests done because you're going to benefit from the results anyway, because a lot of them you'll want me to have 3 months from now anyway. And I was surprised how snooty they were in their answer. They said, well, bring the order in from this physician and we'll determine if what she's asking for is really necessary or not. And then we'll recode them and then we will use our lab. And I thought, well, no pound sand. So I just went to LabCorp. But it was interesting to me, not only the snootiness of it, but the total disdain with which that situation was treated. It just was so sad and concerning. And I have had personally in my labs, as you know, I've been 1 point over or 2 points over or something like that before. And there have been times where things have obviously been out of whack and from the mainstream world, and they just blow it off as normal.
Yep.
It's
It
very,
happens so often, and I'm glad you brought that up. Thank you. 2 points I want to cover there is one, there is this, us versus them mentality that's out there, and again, you kind of already alluded to it, but in this office, I really try to marry that and say, how can we work as a team? I want to work with your primary doctors. So the very first benevolent point I want to make is it is hard as a doctor to be asked to run a lab for somebody else, and here's why. A lot of things that people don't know. If my name goes on a lab order and my signature, I'm responsible for the results. So if a doctor doesn't know why I'm requesting a lab, 9 times out of 10, I'm just going to be honest, it's going to be more ego than honesty to say, I'm just not going to do that. When the real answer is, I don't really know why she wants to run a homocysteine and I'm responsible for that result. So I'm just not going to do it. And I think the majority of the time, that's the situation, which I have no judgment around. The difficult part is that the message that's being portrayed to the patient is this isn't necessary. She's out of her scope. I'm not running it and insurance won't cover it. And so the difficult part in that is that if I'm asked to run a lab for somebody, I will say, I want to contact this provider. I'm happy to order it, right? I just want to understand why we're doing it and what those results mean, because ultimately I'm the one responsible for that.
Mhm.
So if I run a HSCRP and it's high and I don't know why I'm running it and you go have a heart attack 3 weeks later, I'm the last person to sign that lab. Like that, it could come back. So there's a lot of like protective part on that. At the end of the day, though, when we're building collegiality, when we're trying to work as a team for the patient's benefit, it is really nice if these insurance practitioners can consider running a lab. And on my own side, as the naturopathic doctors, we have to learn to sit at the table with the insurance companies, whether we accept it or not. And we're a clinic who doesn't accept insurance. And I know that I have colleagues who just won't even touch that world. But if we can code appropriately for our patients and send a letter over, which I typically will do to a primary care doctor saying, this is why I want to run them. Here are the codes. If they need a PubMed article, again, we'll talk about, I'll usually send that along. This is why it's important to me. Rarely do I get that like hesitation unless it's just, I don't have the bandwidth to do it.
Mhm.
So I think it's going to take, if I were queen of the world, someday, it's going to take all of us sitting at one big giant table saying, are we here for our patients? And if so, how can we work together?
Yeah.
And
Mm.
I don't want to dismiss anything you're saying. And I want to hear if they're like, hey, I don't think this is necessary right now. I want to be like, why? Like, why wouldn't you look deeper? Because maybe I'm missing something too. But those conversations aren't being had openly. And right now, in my opinion, the only people who are suffering are the patients,
Yeah,
which is
that's very
why
true.
a lot
And
of times what I'll do is say, hey, if we get any pushback at all, you just call my front office and they'll give you a quote. Rarely do my lab orders, unless you have a specific condition, cost more than $200
mm,
initially. And then if they do, then I say, hey, we're going to get diagnostic codes from this. The amount of information we're going to get is going to allow your insurance to cover it in the future. And
mhm.
that helps play that game. But really good point about how that works and trying to work together. And I mean, this whole talk, I think I had the word advocacy in there, how to advocate to your providers is not just how to stick up for your lab values, but it's how to say, I want these labs drawn and I want you to work with my other doctor and do these things for me. So I
Well,
think
that's
that's
the
a huge
thing. And
advocacy point.
yeah, and I appreciate that because, as and I speak openly about this, so I'm not revealing a huge secret. I do have hypothyroidism. The mainstream world will not test me for anything but that one.
Mhm.
And I even butted heads with them the last time I was there. I said, it's documented. You're filling my thyroid prescriptions. I have these issues. Why are you just willing to run this one test when I'm already diagnosed with it? I suffer with it. I've had it most of my life. Why
Mhm.
are you not interested in looking to see the whole ratio and scope of what's really going on? And they look at me like I'm just insane.
Yeah. Once you know better and you do better, you're okay with the little horn that's growing out of your head, right?
Yeah,
Like
yeah, yeah.
with my education, I'm used to being looked at like that from a lot of
Mhm.
people. Josephine, I want to pause just to welcome you in. This is you just missed the beginning, which is fine. But I was saying I'd love for this to be conversational. I want to talk about labs in an informative way, but it's also an opportunity for whoever is on live if you want to volunteer to ask questions about your own labs, which I'm happy to answer. I'm going to take a second here because this is what I do for most people in my I draw pictures. But thyroid, I'm so glad you brought up thyroid, Carrie. And I'm just going to go through this really quick. If you're watching this on repeat, you can rewind it and slow it down because we don't have a ton of time to go through it. And this is a very simplistic view of the thyroid pathway. But what Carrie's talking about is so important to understand why we run what we run, right? So I'm not an artist, but we can kind of understand what this looks like. This is your brain. Your brain is going to release TSH, which is thyroid stimulating hormone, to the thyroid. This is the signal that tells the thyroid how much thyroid hormone to make. Now, TSH is the main lab that insurance is going to cover and your conventional doctors will run. Pretty much only this. Some docs will go to a reflexive T4. That's relatively rare. I say maybe 50% of the time I see that. Interestingly enough, though, 80% of what your thyroid makes, the output of your thyroid, regardless of your TSH number, is T4. 20% approximately is T3. T3, the free T3 in your body, is the active thyroid hormone. That's the one that's going to bind to all the receptors and do the things in your body. Both T4 and T3 will send feedback back to the brain to tell the brain how much TSH to make. So if we have a high number of T4 and a low number of T3, our TSH is going to be normal. Even though we might have hypothyroid symptoms, because this one's low, they're offsetting each other into their signals back to the brain. And why might this happen? In Hashimoto's disease, autoimmune thyroid, our TPO enzyme is being attacked by our immune system, which converts that T4 into the T3. So even though we're making plenty of it and it's telling the brain, hey, we're good, you don't have to up your TSH at all, you are suffering with hypothyroid symptoms that are never being uncovered. So what Carrie's saying is if you only run just these two, you still could look completely healthy and normal without any need for medication and feel like shit. And so when you're talking about your labs and these pieces of information are so important, you don't have to run these every time. Once you have a diagnosis of Hashimoto's, I don't run antibodies every single time we check your thyroid. It's let's make sure that we have a balanced output. How are your symptoms? How is the medication being handled? And we have alternatives to treating too. We can give levothyroxine, we can give liothyronine. There's Armour thyroid, there's NP thyroid, there's nutrients that we can give to help the pathway along. And so without doing a whole biochemistry lesson, that's a great segue, Carrie, into saying why do labs matter and how to advocate for,
Yeah.
I I have this condition and I can't tell you how many people in their 7th decade I'll come in and diagnose with Hashimoto's for the first time in their life. And their levothyroxine is doing nothing for their symptoms because we're funneling into a system that's broken so that T4 doesn't get converted well to T3.
It's just
Um,
criminal. I mean, it just really is. People are just walking around trying so hard to be well and just perpetually falling through the cracks.
That is such a lovely statement. People are trying so hard to be well. I love that. And I want, I want people to be well. And so many people joke with me. They're like, "Yeah, well, you wouldn't have a job if we were all well." I'm like, trust me, the planet is sick enough that all of us need a little support,
Yeah.
in general. So I do want to step back for a second and talk about reference ranges. So the reference range of a lab, this is really, really important to me. The reference range of a lab does not follow clinical research. The reference ranges of labs do not adhere to clinical research, which means that if we know that a homocysteine level between 10 and 11 is more likely to cause dementia in a person with Parkinson's disease, the reference range on a lab still goes up to 14.5, or on some labs up to 17.2 as being normal. So it will not flag a 12, a 13 as abnormal to say, hey, this could be neurotoxic and inflammatory for your body. It's still falling within normal ranges. Reference ranges are based on two things: population data and statistical analysis. So population data means they take a large group of healthy individuals, just a big group of healthy individuals. They're carefully selected, and then they take the average, which is the mean, and a standard deviation of 2, which is the variability outside of the mean. So you end up with the middle 95% of the results from this healthy population, and that gives you the reference range for the labs. So that healthy group of people could be a bunch of 40-year-old men. It could be, like, who knows how you fall into that healthy group of people. Now, sometimes there are separate subgroups within a lab value, right? We look at estrogen, testosterone, things like that, and it'll say, well, if you're between this age and you're a female, it should be this. If you're between this age and you're a male, it should be this. So age, sex, pregnancy, things like that can be divided into subgroups. But it's really interesting to me because there's a quote at the bottom of this that says reference ranges are intended to guide healthcare providers in interpreting lab results, but are not definitive boundaries between health and disease. And I love that statement. Your reference range does not determine health and disease. It's just there to guide us into interpreting your lab results. Now think back to how many hundreds of lab results that we've gotten collectively, and then you get a note saying, hey, everything looks good, right? Just because it's not bolded doesn't mean that it's good. Even if it is bolded doesn't mean that it's bad, right? So they're there to help us interpret things. I'll say labs are more like cooking. They're definitely not baking, right? Baking, you have to be precise. Everything has to add up. You have to be so perfect when you're baking to get the good result. Cooking, you're kind of like, well, it could be a little bit more of this. You could need a little bit more of that. I need some more flavor, some spice. Labs are not precise. And now that you know, hey, we just took a whole bunch of people, and then look at the world is unhealthy. I mean, Carrie, you just said it. Everybody's trying to be healthy. Our world and our population as a whole is unwell. And so we know for a fact, I actually saw this happen, that the reference range for glucose actually has changed over time, what a healthy glucose is, because what we're considering healthy population is actually unhealthier. So now we're accepting worse numbers, even though the population, because that's what's considered healthy now. So when we know better, we do better. But I don't know about most of you. I know there's 2 of you here now, but watching later, I don't necessarily want to be compared to the general population. No offense, but
Never.
we all ain't looking so good as a whole. So if you're gonna
Yeah.
tell me that, hey, you're doing okay compared to everybody else, and be like, I don't actually love how that feels. But it's important for people to know that this is a guide. This is not, you are absolutely fine if your numbers look good. Any questions on that little segment here that we went through?
Well, I don't mean to jump in if Josephine has one, but and maybe I shouldn't say because this is branding, but I'm just curious, do you think with like Heart of Hope Health, going back to the insurance component, do you think that type of facility would be more willing to work with you on your lab issues, and they seem, from what I've heard of them in the community, they're extremely open-minded and cutting edged. And so do you think that would give a better outcome in terms of actual diagnostic tests and being covered, and their willingness to work with you and vice versa?
I'm really hoping so. I have a lot of shared patients with Heart of Hope, so I've had really good luck with them personally. I won't speak
Okay.
broadly to it because I don't want to put everybody into one bucket. That being said, though, and this is not an ego thing, I think it's just my own value system. I work really well with every primary care doctor that I try to get in touch with. And if they don't want to, then oftentimes, and it's not a personal thing, I'll tell the patients, I'm like, hey, do you mind finding a different one? I want you to have your insurance to cover this. I want you to have a team. I believe that, the majority of my practice is over 65 years old. And so I want people to have a Medicare doctor, to have that insurance coverage and that safety net where we need it. I don't want to be your primary care doctor. I want to be your wellness doctor, right?
Yeah.
I don't want to go check the box that you've had your mammogram and your colonoscopy, and I want to see the results and improve your health and optimize it. And I want to dig deeper into what that looks like. And oftentimes when I usually will send a note, a lab wish list, I call it. I'll explain I don't take insurance. This would really benefit our patient. Rarely does it get rejected. It
Hmm.
really doesn't. I have a lot of PCPs who I work well with. Heart of Hope is a great facility. I think I said I've had really good luck with them as well. The one thing that I do see a lot, and I don't want to throw anybody under the bus either, is that keep in mind that in the spectrum, of physicians out there, you have your conventional MDs they tend to be algorithmic, and I don't think it's their fault necessarily. It's just what they have time for and what they've been trained. Hey, this medication will work well for this set of circumstances. Then you have your pure naturopathic doctors who really don't even run labs, right? They're like, hey, do constitutional hydrotherapy and take your herbs, and here's your homeopathy. And we don't even need to mess with that. We're just going to listen to our body. And that's wonderful too. And then along the spectrum, you have all kinds of different practitioners, integrative, alternative, whatever it looks like. The ones that honestly sometimes I have the biggest concern with is the conventional docs who become functional medicine practitioners through an online certificate and say, oh, now I know how to do naturopathic medicine. I'm going to order a bunch of tests. I'm going to give you a bunch of supplements and not really have a huge amount of training in what that looks like. The differences in the magnesium chelates, the senna can be addictive, right, for constipation. So there's certain things that I see over and over and over again from this particular group. And again, I don't want to throw anybody under the bus. It's just, it is a science. Naturopathic medicine and understanding the body is a science. And when you're choosing your team, it's important to understand that there's different levels of knowledge base on that. And I will be really honest. If you're ever asked to order more than $1,000 of testing or $500 of supplements in one visit, run, run.
I heard a lecture the other day from a naturopath, and I'd never heard this phrase before, and I thought it was very telling. She said she considers that to be nothing more than green big pharma, and that is a horrible practice, and that it's nothing different than what big pharma does with their overriding of prescriptions. And I thought, wow, I'd never heard that phrase before, green big pharma.
Yeah, we use it a lot in med school. They would call it green allopathy
Hmm.
is what they would use. And sometimes, I kind of joke and be like, I'll tread on green allopathy in my way because I don't shy away from using prescription medications when and if needed and indicated. And then we'll talk about why the side effects are what they are and how we can mitigate that with knowledge of deficiencies. But I agree with the fact that you can go into a lot of offices and walk out with a giant bill and be like, I don't know. And, a pharmacy is pharmacy, whether it's natural or it's prescription. Your liver and kidneys have to filter it out. Your body has to be able to absorb and metabolize it. There should be a therapeutic dose and a time frame behind everything that you get. Hey, I'm going to put you on this. We should see a change in 3 months, either in your symptoms or your lab values. Whether it's natural or not, there's very little that I think humans need to be on to maintain health forever. Now, if you have a condition, Parkinson's disease, type 2 diabetes, something that requires you to be on something long-standing, that's a different situation. But in general, even your natural medicines, and I'll stand on the rooftop until I get, popped off by all my colleagues, saying natural medicines are still medicines.
Yeah.
They still have to be processed in a lab somewhere. We're extracting constituents from plants. These things are not as natural as you might think they are. So there's a therapeutic benefit that we should be prescribing these with a responsibility similar to the orange pill bottle that you get from the pharmacy, saying, this is why you're taking it, this is what we should see, and this is how long that should take.
Very well
Do you
said.
feel that way also about like the extra D and the extra B vitamins?
Absolutely. Absolutely. If you, and we'll talk about that too, because I'm going to go through some lab examples I had mentioned earlier, but all of your vitamins and things that you're taking, if you are severely deficient and continue to be deficient and we supplement orally and you're not seeing those lab changes, those lab values change, then I'm going to say, what's going on with your gut? Do you have some sort of other condition that you can't absorb B12? It is a huge responsibility, in my opinion, especially in the supplement world. There's financial, there's consumer quality. We don't have a quality check. The FDA doesn't regulate supplementation. So I believe personally, and take it or leave it, that we have a huge responsibility as naturopathic doctors and prescribers of supplements to do quality control and therapeutic dosing. And a lot of times when people come in with a laundry list of supplements, the first thing I'll do is kudos to you. You've advocated for yourself. You've done research. You know that your body is needing more. Carrie, you're laughing. I'm not calling you out personally. I promise there's so many more of you
My
out there.
shopping bags of vitamins.
And then I'll kind of pull it back and be like, oh, your poor liver and kidneys, right? Like you're taking too little of this, too much of this, this isn't going to make a difference in what you're hoping that it would, because we do have data and research behind most of these to say you have elevated triglycerides, you need 4 grams of high quality fish oil. So if you're taking one of your little Nordic naturals a day and thinking I did my research and I'm going to bring down my triglycerides, you really are wasting your money, because it's not going to be enough to do it. And you're going to continue to have high triglycerides. So does that answer your question, Josephine? A little bit?
Am I muted? No, I'm good.
Nope.
You can hear me. Well, what about which vitamins get processed in the kidney and liver? All of them?
Most everything. Yep. Most everything that we put in orally has to be absorbed in the GI system, has to go through phase 1 and phase 2 metabolism in the liver, and then has to be excreted through your kidneys or your stool. So that just is kind of broadly every single thing that you put in your mouth.
Yeah. That's interesting.
Yeah, I know.
Yeah, kind of
Once
scary.
you really take that
scary.
on board, you just want to give your liver a little hug, right? And be like, oh, good job. You've been working so hard.
Yeah, well, I have to admit, I was very disgruntled when you pulled me off all my stuff. And of course, it didn't go well. I started getting leg cramps and needed the magnesium back. And then I needed the B vitamins back. But I have to admit, when I take more things than you have told me bare bones to do, I feel sick the rest of the day. And I don't feel as good as when I don't take all of the stuff.
Mhm.
And that was very eye-opening to me, because I mean, I've taken handfuls of vitamins and minerals my whole life because of celiac disease, just handfuls of them.
Mhm.
And I've never felt good.
Yeah, we don't want to, we want to heal. And, a lot of times we live on a planet that's toxic. So it is challenging these days to just exist as humans and say we have this self-healing mechanism and we just have to trust our body. And as much as I want to do that, I also live on the planet and have my daily stresses and an occasional glass of wine. And I know that there are things that are going to impact our health in general. And so aid and assistance is necessary. However, you want to know, like you said, like what matters, what do I actually need? What is combating, the leg cramps? Okay, great. I can take 1 pill a day and now I don't have this anymore, instead of thinking I needed 5. Now they're gone. We don't know which one was actually working. So yeah, kind of beating that dead horse. I'm going to share my screen here for a second because I do want to talk about, I want to show you some of these tools that I think are important. No, this is not the one I wanted. This is the one. So I don't know if you're familiar with this, but I've got so many patients who come in and they say, hi, nice to meet you. My YouTube doctor told me to fill in the blank. And I said, oh, your YouTube doctor. How much are you paying your YouTube doctor? Are they looking at your labs? Do they know you by name? You know, it can be a little bit of a smart ass if you can't tell already. But really, they have great information. So I'm not slamming YouTube, TikTok, podcasts, whatever you follow. I think it's great. I want you to be informed. But if you were to go onto scholar.com, this is scholar.google.com, this is an excellent resource for just getting an abstract, getting some information about what you're trying to learn when you're listening to your podcast. If you're interested in diving in a little bit deeper, I think this is a great next step for most lay people to say, I want to know a little bit more. Now, you don't have to pay for the full article. A lot of times, like I said, and I'll show you, they'll have an abstract there that gives you the general gist of what we're going for. But again, keep in mind, those YouTube doctors don't know you, right? I got in a knockdown drag out with one of my patients, right? Who had this hyperlipidemia, family history of heart disease, yada, 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 and was on early onset of dementia. And he's telling me, my YouTube doctor says cholesterol is not bad. I don't know where you're coming from. Cholesterol is not bad. And I said, I get that it doesn't have to be bad. We have an MRI that shows that you have, white matter microvascularities, your lipids are high, you're having dementia, your inflammatory markers are high for your cardiovascular system. Cholesterol is bad for you, right? It doesn't mean that it's bad for everybody. And I think when we look at these fads, we can go back to the beginning of time. And at my age, I can remember when eggs were bad, right? And butter was bad. And I can, when milk was the thing that we all had to drink because all the celebrities were drinking it. So we go through these fads where we want to say, this is what humans need. And what humans need is really individual care because we're individual biology and chemistry and everything like that. So this is a great kind of next step to go. So you can go in there and you can write, as you can see, some of the most recent searches I have: vitamin B, risk of dementia, iron levels in Parkinson's disease. So you can go in there and search to make it as individualized to you as you want. Because we already know, right? Labs are not based on clinical research. It's population based. So if you have a condition and you have more information about your labs and you want to know more, this is a great resource for you. So again, I can show you a couple, like I said, I was just researching this. This is one that I send to conventional docs all the time. They tell me your B12 levels are fine. And I'll have a patient on oral B12 for 3 to 6 months. We don't see their B12 levels rising as much as we'd want to. Say, hey, let's ask your primary care if you can get a prescription for sub-Q shots. Let's get you some shots of B12. Let's see if we can boost those levels up again. Maybe you have intrinsic factor antibodies or pernicious anemia. Maybe there's another reason we just can't get this B12 into your system. Their conventional docs look at their labs, 300. I've seen as low as 250. Oh, you're fine. You're in the normal range. Again, we have clinical data now that shows, and I'll pull this up. This is the greater than 60% of people with B12 over 600 were dementia-free 15 years after a Parkinson's diagnosis. Less than 20% of people with a B12 under 627 were dementia-free. That means 80% of people who have Parkinson's disease and a B12 level under 627 are going to develop dementia. So when we're looking at, well, most people don't have a B12 within this range, we can now narrow that down with these clinical research papers to say, well, for this particular patient, boosting their B12 level is not just like, hey, this is a goal of mine because I'm an ND woo doctor. It's because, Dr. McCarter here wrote a paper saying 80% of people with a Parkinson's diagnosis will get dementia if you're below 627. The reference range, by the way, is like 230. So that's where I really want to, beat that in to say, this is not my opinion. I'm not out here saying, oh, because I'm a naturopath, I want to boost you up. I want to do this. We have clinical research to show it. And I think because of time constraints and bandwidth or whatever the case may be, we're taking these lab reference ranges as gospel. And I think it's dangerous.
Yeah.
The next one is homocysteine. Homocysteine is the most sensitive test for a B12 deficiency out there. So B12 can get into your bloodstream. You can have plenty of B12, but whether or not your body can use it or not for the functions necessary is a second question in the biochemistry. And homocysteine levels, we know to be cardiotoxic and neurotoxic. In this paper, we know that homocysteine levels, where did that go again? Oh, it went somewhere. Sorry, I'm trying to find this on my highlighted. Okay,
It's on the third
It's-
line of the abstract. Homocysteine levels due to metabolism up higher, way up. Up.
oh yeah.
up.
Well, maybe not on that page. It's the so this is the abstract, but what we have, I pulled it down somewhere. Okay, so here's what I want to show you. Here's reference intervals of homocysteine. So this is breaking down into age and male and female. And you'll see that 18 to 60 years old, it goes up to 14.5. Riddle me this, the reference range goes higher the older you get. So you're allowed to just have more toxic substance in your biochemistry because you're older. We know that in Parkinson's disease, again, if you don't know me, you know that that's my specialty. In Parkinson's disease, if you have a homocysteine level above 10 or 11, we see a higher risk of dementia. And so the neurotoxic levels of homocysteine in the clinical research do not match the reference ranges. So just because 95% of people 61 to 70 years old fall into this reference range does not mean that it is good or optimal. And I'll tell you why I think the older we get, the bigger the reference ranges go. And it literally just now is like ringing the bell, right? Is because we don't absorb B12 when we get older.
Why not?
We have less capability to absorb it. So of course that age range is going to have a higher number of homocysteine because we don't have as much B12 in our body, which is necessary to bring homocysteine levels down. And not just any B12, you have to have the ability to methylate your B12. And so we look at these reference ranges and it strikes a nerve, obviously, because I chose this topic to talk about because it's just, they're not accurate. It's not based on clinical data. It's based on population. Go ahead, Josephine.
Why is that? I mean, why should it go higher or lower as you age? That's the thing that always makes me angry is because, for my age, I'm great,
Yeah.
But I don't want to be great for my age. I just want to be great,
Oh, Josephine, I want to hug you because I always joke, I'm like, if this could be on my epitaph, it would, but it turns out my epitaph is like a mile long now with all the things I just want. Ageism in the healthcare system is the one thing that by the end of my clinical week, my poor husband will just hear about. I get so fired up by the end of my clinical day that my last patient usually gets a couple F words, not at them, but I'm just like, you got to be kidding me, right? Like again, and it's week to week. So I agree with you. You should not feel great for your age. Your kidneys should not work well for your age. They should work well. And yes, we're going to have oxidative stress and we're all going to age and death is the only thing that we can all count on. But like I'm saying, the reason that these numbers are going up as we age, in my opinion, right, is it's because it's population based. The one thing that we know is that our ability to absorb B12 diminishes as we age. So if we don't have as much B12, then we're going to have higher levels of homocysteine. And if we're just studying the population, that's going to look acceptable.
So
is that an enzyme issue that causes our inability to absorb B12 as we age, or what is the trigger that causes that to happen and be kind of predictable?
Well, I'm going to default to it depends, but it's also generally speaking, we make less hydrochloric acid as we age.
Okay, yeah.
Sometimes our smell diminishes, so we make less digestive enzymes, which inhibit our ability to absorb B12. There's pernicious anemias, there's GI issues, there's less intake of higher protein foods because of teeth issues, dentures, whatever the case may be, but we tend to see less absorption in general, broadly speaking, as we age, lower absorption capabilities of all nutrients. But with this particular measurement, because it's the most sensitive test for B12 deficiency, and when you're talking about really any condition, because B12 is a cofactor for it all, but neurologic specifically, I'm not just going to check your B12 levels. Because you might have plenty of B12 in your bloodstream, but if you can't methylate it and you can't use it from there, then you're also going to have an elevated homocysteine. And I'm going to show you an example of that here. Actually, it's a good segue. So this person's HIPAA has all been marked out, but I'm going to go down here and show you his methylmalonic acid here. All looks normal. So that's another way to tell if there's a B12 deficiency. But now we go down here and look at homocysteine at 17. Reference range was 0 to 17.2. We know 10 to 11 is cardiotoxic. This person has Parkinson's disease. We were able to bring down his homocysteine level. His current one is at 7 right now, and he has cut back on his medications by 20%.
Hmm.
And so that, I mean, it's not the case for everybody, right? It's not just a one and done thing, but you're looking at these labs and you're saying, how does this relate? Why does this matter? And so just, understanding what your labs are and how to advocate. Again, I highlight this, white blood cells, 8.6. In the normal reference range, clinically speaking, 8.6 means your body's working on something, right? Like it might not be critically care, like you have an infection, but when I'm looking at labs, I go through with my little highlighter. I'm like, hey, that's high normal, that's low normal. And then I start looking, if you've ever seen the movie, is it A Beautiful Mind, the Russell Crowe movie? Where he
Yeah.
kind of looks at the board and he starts to see things and it all comes together, but then I think he gets a little too far carried away because then he's seen things that don't exist. But when I look at labs, my colleagues often laugh at me and they're like, how'd you put that together? But I'll look at it and I'll say it's like one of those pictures that don't make any sense unless you cross your eyes and then you see the image come out at it. And when you look at labs, you really have to do the same thing. They're an interpretive guide. So if I'm seeing a few high normals here and then I see a couple low normals, now I'm looking at, oh, is this dehydration? I'm seeing this enzyme and this protein are both a little low. Is that liver function? And so we can start to get a picture of how the body's working, where it's putting its energy, where it might be inflamed, how this impacts this, and this all makes sense. So I don't look at labs and go immune, liver, kidney, but break it up and say, okay, the reference ranges tell me I don't need to worry about it. They say, what do each one of these values, what are they trying to tell me? How is the body communicating to me with these values? And even if they're not bolded, are they trending one direction or another? And the more labs we get, the more we can understand how the body's adapting to therapies. To kind of go back to your question, Josephine, we can see and listen and actually communicate with the body through labs to say, how are you adapting to the therapies? Are we seeing this trend down? If we're not, and we were expecting it to, now what questions do we ask? Do we run a different marker? Do you have pernicious anemia? I have a mid-70-year-old man who I just diagnosed with pernicious anemia for the first time, which means he doesn't make intrinsic factor to help his B12 get absorbed. So he's been taking oral B12 this whole time. Levels never go up. And so we want to find those answers so we can treat appropriately. And then, like we talked about at the beginning, I think you missed this part, Josephine, then I can send a nice little message to his PCP and be like, yo, John Smith has, pernicious anemia. Can you please prescribe B12 shots? Hi, you would have never run those labs, but now we have it. Now we've got this going on. So we want to advocate in that way. And when you don't have somebody in your corner doing it for you, I wanted to do this lecture so that you could start doing it for yourself, so you could understand a little bit more about what that looks like. The next example I want to use, and then I want to take a couple questions before we wrap up, is this person here who I ran labs on back in 2021. And so I'm a huge fan of iron. I run iron. I think it should be standard practice. It is avoided at all costs in the conventional world. I do not know why, but the amount of iron storage disorders and or anemia that I've diagnosed in my 5 years as a clinical practitioner, I had no clue I'd be talking about iron as much as I do. But you can look here at the CBC, you're looking at his immune system, everything looks pretty healthy, but his MCV and MCH are both high. MCV and MCH show us the size and shape of your cells. And so in a conventional panel, when they would run this test, they would look at this. Typically, you won't even have a B12 folate ran, but the knee-jerk reaction is that you're deficient. And they'll prescribe you B12 and folate, which had happened with this gentleman. I've been on B12 and folate. I've been on it for years, in his 70s. Terrible, almost like heart failure type presentation. Just a pretty poor health individual when he walked in. I said, well, that's interesting. So we looked at those after his first lab and I tested him again. I said, well, that also can mean that you have too much iron.
Hmm.
So we ran his iron.
Cool.
His iron saturation was 81% and his ferritin was 999. This gentleman in his 70s, I got to diagnose with hemochromatosis, which is an iron storage disorder, which means your body just holds on to all the iron that it gets. It doesn't let it go, and it can cause heart failure, liver disease, and the rest. We got him on therapeutic phlebotomy. He is now prescription medicine free and without symptoms.
Would you repeat that? You put them on what?
A therapeutic phlebotomy. So
What's that?
really the only treatment for hemochromatosis is to donate blood. You just gotta go give away your blood. You got too much iron in it. So we just take it
How,
out.
how often? I have high iron also, and I'm
Yeah.
going to donate blood. But
Yeah. Well, so donating blood to be lovely is lovely, but therapeutic phlebotomy is actually going to a place like Vitalant and actually giving your blood, and there's a certain amount. So it should be prescribed and then managed. So each person with hemochromatosis accumulates at a different rate. So I've got at least 15 patients in my practice with hemochromatosis, all on different schedules of phlebotomy. And we come to that by it's trial and error. Okay, I want you to go give blood. We're going to test 2 weeks after. We're going to test 3 months after, see how quickly it accumulates. You may have to go every 8 weeks. You may have to go every year. So it just depends on how quickly your body accumulates iron.
and what causes that?
It's a genetic disorder.
Oh.
Mhm.
So is that blood then actually safe and good to use as a donated blood? Because it seems to me it would
Nope.
be so high in iron that,
No, it doesn't say it's therapeutic phlebotomy. It's just taking your blood, but it's not you don't donate it to anybody.
so what do they do with it?
I'm sure they toss it. I don't know. Medical
Okay,
waste.
yeah, because I would think that would have to be the case with all
Yep.
that iron.
Yeah.
Yeah, huh, that's interesting.
What
You
about
know,
leeches?
I'm sorry, what,
Leeches?
Josephine?
Leeches could work. And so I have a whole protocol for high iron too. There's iron rich foods you can avoid. Black tea actually inhibits iron absorption. So a lot of people have hemochromatosis. You don't want to donate all the time. If you can drink black tea, I mean, I have one gene for hemochromatosis. I'm really open about it with my patients, and I have black tea in my fridge all the time. And I just keep it steeped and drink it with dinner because I don't want to give up the foods that I love that have iron in them. And you go from there. But like I said, it's all individual, but these are examples of where I see you can't just give somebody a B12 supplement because this is high, assuming that it's either B12 or folate deficiency. There's other reasons for every single lab value in here has an explanation for it. And rarely is it just, it has to be this. Sometimes I look at it and patients will be like, why aren't you panicking, doc? Like all these are bolded. I'm like, girlfriend, you were dehydrated when you went in for your draw. Oh yeah, it was a fasting draw. I didn't drink water, so everything looks wonky. So if I'm ordering labs and I get the chance to talk to you, better bet I'm like, please be hydrated. Don't make us do this again because you got a bunch of funky numbers.
Can I ask your final official word on this? Because I get conflicting information on that. Because when you call to make your lab appointment, they say fasting, don't drink water, and the medical doc say, yeah, no, don't drink water, that'll screw everything up. So you do go in dehydrated. But then when I talk to you, you say, please go in hydrated. So how much should we actually drink the night before and the morning of fasting labs?
Fasting is fasting from food, fasting from any sort of calories. So you need to be, typically I'll say a 12-hour fast from anything food related. You can drink water. Now don't drown yourself because it will change your osmolality and your electrolyte balance and things like that. But absolutely, positively go in hydrated, generally hydrated.
Okay, good, because I've not done that most of my life because I've listened to the wrong people. So consequently, I wonder what all have my labs actually been all this time because I listened to them and didn't drink water. And some of them used to tell me don't even brush your teeth because that's too much water. They used to tell me that.
I would, even if that's maybe the science, that's not going to change your lab values that quickly. My favorite is when people tell
Okay,
me,
good.
well, my A1C is high because I had birthday cake last week. And then I always joke, I'm like, A1C is a 3-month average there, honey. That's 3 months worth of birthday cake. That's not just last night.
I've actually said that to you. That was the last time we ran the labs. I said that to you, but no, it
Yeah,
wasn't.
so you can't hide the Christmas cookies when you run
Yeah.
an A1C because that's
That's
gonna
funny.
be. But I mean, and I think in general, those are a couple examples, but diving deep into labs, you know, call me a nerd or what you will, which a lot of people do. For me, I get to have a direct communication with your body when I look at labs. And I think of it as nothing less. And my husband can vouch for this. I talk to myself when I'm terrible, like, what are you trying to tell me here? Like, what's going on? Why aren't you communicating here? Why is this impacting this? I want to know what your cortisol level is. I mean, I'm talking to my computer the entire time I'm looking at labs, and it's not just everything looks good. It's okay, maybe everything is within the normal range. Are we trending? Are we looking different? Based on this patient's symptoms, they're telling me they feel a certain way. And if iron's good and thyroid is good and their B12 is good, why on earth are they exhausted all the time? Okay, I want to run a sedimentation rate. I want to look at their autoimmune profile. What are we doing next to make sure that I'm addressing how this person feels? Rather than just saying, well, your labs look good, so we don't need to do anything about it.
Well, I've always said, to me, you're the Sherlock Holmes of labs, because the way you put things together, it's fascinating how your mind works to me, because you have, excuse me, you have put things together and seen things that I knew the mainstream people had missed, because I either knew enough about what I was looking at and thought I understood it, or I could couple it with how I was feeling. And I knew that they were missing the mark completely. And then I'd bring them to you and you'd be like, yeah, okay, there you go. This and that and this. And it's just astounding the gift you have in that department. I mean,
I appreciate you calling it a gift, and I'm never going to turn down a compliment, but it's a gift that all medical providers really should have. It's the basic understanding of anatomy, physiology, and biochemistry to say, what does this mean? Unfortunately, it's been narrowed down to, like I said, to being like baking. Like, if this isn't off, I'm not going to do anything about it. But there's so much more information between the lines in labs that, again, for patient advocacy, I could go on and on and on. You know, if this was a room full of healthcare providers, it would be a whole different conversation, because I'd be like, you know, we need to look deeper. Running an A1C without an insulin on the second test, if it's off the first time, is ridiculous. Why would you just check that? We need to see how it's being taken up into the bloodstream. Running an A1C without a CBC is borderline malpractice, because if your red blood cells are low, then your A1C is falsely low. If your red blood cells are high, your A1C is falsely high. Your body depends on other systems for accuracy. Everything is interconnected. And so when you look at these and you try to isolate, you're really missing the whole picture, which is what we're looking for when people come in with health issues. Now, my favorite day on earth, don't get me wrong, although I love being a nerd and a detective, my favorite thing on the planet is getting a really funky thyroid panel and being like, it's thyroid, take your meds, go home, be done. I'm the most conventional doc you've ever seen, because then it's just bippity boppity boo. Maybe twice in my whole practice has that ever happened, because you might feel better, but if you've had an abnormal thyroid axis for a couple of years, your cortisol might be off, your reproductive hormones might be off, you might have gained some weight, right? There's always going to be more to the picture, and we want to optimize health. But, you know, those are fun times when you can say, this was off, this is the thing, let's fix it.
Yeah.
But that's
fun for the
not how we're
patient, too.
designed.
Yeah, it's fun for the patient too, because it's a relatively easy fix.
Yeah, it's a quick answer.
Yeah.
What other questions do either of you have? And then if you don't mind, like I said, I'm going to remember not to do open forums at 11 on a weekday, because I don't think a lot of people can tune in, but tap into your general audience. And if there's anything that you think people might want to know, feel free to ask.
Is there anything about taking hormone replacement that you should be looking for in your blood tests besides the hormone levels?
Besides the hormones. Yeah, I mean,
Yeah.
your general reproductive hormones, but I would always look at cortisol and thyroid along with that. I'd be looking at your lipids. Reproductive hormones, especially for women, is something way outside of my wheelhouse. But what I do when I start to think in that realm with my patients, the very first thing I'll talk about is GI health, because the two things that are recycled when we have GI inflammation are our lipids and our estrogen. And so if you're needing to be on hormone replacement therapy and you have elevated lipids and you're constipated, then I'm going to say, yeah, you can go see an HRT doctor. You can talk to repros, but until you poop, it's going to be really hard to detoxify yourself from this estrogen overload. So much GI health and hormone is related. So that would be, one of my very first questions is, again, palliative care is huge. Hey, let's get you on the thing that you need to help you feel better, but let's also figure out why it's off. And, that GI picture is just so instrumental in hormone balancing. Cortisol as well, right? Stress, trauma, vagal nerve dysfunction, and then your thyroid axis is just, it's touching all of it. It's our puppeteer.
I'm speaking more postmenopausal, not
Same.
like I mean, there's a good reason my hormones are off because I'm almost 70. So
yep, that's nature's, turning certain things off for the health of the being. But being on it, you want to manage those hormones. But again, you look at your GI health, you look at your overall toxicity, right? We know that the estrogenic invasions, I guess I'll put them, like things that can alter it, the plastics, the BPAs, the soy, there's so many things that can alter your estrogen in our environment. And really estrogen to me equals detox. How is your liver? How is your GI? Do you have the ability to detoxify estrogen? When we're looking at balances and things like that. But yeah, I think a deep dive into your GI system is always necessary when you're talking about hormone balancing.
Thank you. That's great.
Yeah.
Bone health. I am a naturopath who supports DEXA scans. I'm just going to say it. I'll be crucified by half of my colleagues. I don't care. Bone health is so instrumental. Not only is it instrumental, I don't get fearful if you have a diagnosis. I want to know, okay, do we need, what do we need in our system? Our body only absorbs 20% of oral calcium. So rarely is oral calcium the answer for bone loss, right? So again, we're looking at hormone balancing. We're looking at your GI system. We're looking at acidity. There's always more to the picture. And Carrie and I started before we even recorded saying it's not always cut and dry. There's always something more to the picture. And if you're not responding in a way you should, or your labs look funky, there's always another question to ask to figure out what's happening. And that's the beauty of the human body, I think.
Yeah.
And the frustration of the human body.
I was secretly thinking that part. I wasn't going to say it. Yes. But
no.
well, this has been fascinating. I will email you as we discussed, but I will do it through, I'm assuming, the office, and just ask them to forward it to you. Is that how you want it done? Okay.
Yeah.
So, wow.
Or for all of you listening, the patient portal, if you are technologically inclined, is the best way. But yes, email works.
I tend to overshoot the character limit in the patient portal.
No, don't go telling people that you can buy.
I'm sorry.
Limit. There's a reason.
I'm sorry. Okay, no, I'm sorry.
There's a reason we give you 500. I'm going to mute you, Carrie.
Yeah, but I'm chatty and a writer, so I use a lot more, words. But anyway, I'll work on that. And I'm sorry I outed the
you're good.
System there.
I joke.
Let the cat out of the bag.
Josephine, what else do you got for me?
That's it.
Okay, well, I appreciate you both showing up. Like you said, hopefully people can watch it at the back end. My hope is that if it does get good feedback and people have questions, which usually tends to happen, what we'll do is I'll just host another one and maybe we'll go into some alternative labs, understanding why you would do something. But at the end of the day, the big rules are you don't have to necessarily understand everything in your labs, but you want to find a provider who does. Your naturopath, if you have one, can work with your primary care doctor. You might just have to shift around your team a little bit, but there's no reason that we can't play nice together. And if your naturopath can't defend why they're doing certain things, so I will go ahead and say that if you can't show the clinical research and they're just doing labs to do labs and it's not changing your treatment, then that might be a cause for concern. Don't sign up for more than you need. You don't have to do thousands of dollars worth of testing and take $500 worth of supplements because something else is probably going on. What did I say? 10 max, Carrie? You should be on 10 max. Otherwise we check your gut.
Yeah.
We're not getting what we need out of 10 things in your pharmacy. That's not just supplements. It's not just prescriptions. Then we got to check and figure out why your body's not assimilating that or why it needs more.
How do you check someone's gut? What lab references the gut?
Well, you can look at nutrients through blood, so you can look at the vitamins, you can look at iron, you can look at some different inflammatory markers through the bloodstream. Stool is my go-to for that, a comprehensive stool analysis, look at inflammatory markers, digestive sufficiency, the microbiome balance. Symptom picture, honestly, sometimes if people just come in and they're like, I'm on all these supplements, I'm not getting the benefit, their labs still look kind of crappy, pun intended. I'll say, you know, tell me about your bowels. Are you bloated? Do you have gas? Do you have heartburn? And if the symptom picture aligns, you don't even have to spend money on all that test. Let's get started on a brief protocol, a couple different supplements, see if it improves as a trial. And if you start to feel better, then let's go down what we know would be helpful with this diagnosis, that if we could clinically make it. If it's not helping, then that's when I might say, hey, this lab would then change my treatment outcome. Let's run a stool test, a comprehensive one, and see what we need to do to help this.
Perfect.
But
Yeah.
there's a reason that your body needs more than 10, and that reason should be uncovered, in my opinion.
Thank you so much. This has been very good information.
Good.
Yeah, it has
Good.
been.
I hope so. I appreciate
As
you both being here.
always.
Have a wonderful rest of your day.
Okay, you too. Good to see you.
Of course. Bye.
Bye-bye.